Today we're going to be tackling a really complex topic, ovarian cancer. We'll be walking through the entire journey a doctor takes, from those first vague, easily missed symptoms, all the way to a personalized treatment plan. And we'll be using a detailed set of medical notes as our guide.
Alright, so what's on the docket? First, we'll get into why ovarian cancer is often called the silent disease. Then we'll see how doctors answer that first critical question: is it a harmless cyst or is it cancer? From there, we'll explore the main types of tumors, before we finally see how all that information comes together to build a very precise battle plan for treatment.
So, let's kick things off with the single biggest challenge in fighting ovarian cancer: actually detecting it. Its symptoms are notoriously subtle, which makes it incredibly difficult to catch early.
So that really begs the question, right? What makes this disease so sneaky? Answering this is absolutely key to understanding the challenge for both patients and for doctors. Well, the answer really lies in its symptoms. They are just frustratingly vague. Things like nausea, loss of appetite, or maybe the discovery of what's called an adnexal mass, which is just a lump near the uterus. You can see how these could all be easily dismissed or mistaken for something way less serious. And that means the cancer often isn't found until it's already more advanced. So, let's say a mass is found on an ovary. The next critical step is to figure out exactly what it is. Are we looking at a harmless cyst, or is it something more serious?
And this is where doctors start playing detective. You see, a benign or non-cancerous mass is actually pretty common in women of reproductive age. But there are several major red flags that point towards a malignant mass. For example, if it appears in someone very young or postmenopausal, if it's growing rapidly and there's weight loss, or if it feels solid instead of being filled with fluid.
And wow, when you see it on an ultrasound, the difference is just night and day. On the left, you've got a benign cyst. It's often simple, smooth, and has just one chamber, unilocular. But then you look at the image on the right, and you see features that are way more concerning: thick walls dividing the mass, solid parts, and especially these little growths called papillary projections that are highly suggestive of malignancy.
So once malignancy is suspected, the next step is to classify the tumor. You can think of this as creating a kind of family tree for ovarian cancers. The World Health Organization system helps oncologists understand exactly what they're up against.
Now, this breakdown reveals something really crucial. The vast majority, a full 90%, of ovarian cancers are epithelial tumors. These are the ones that arise from the cells on the ovary's outer surface. The other types, like germ cell and sex cord stromal tumors, are far less common.
Okay, now let's zoom in a bit. Let's take a visual tour of what these different tumors actually look like, both to the naked eye during surgery and under the powerful lens of a microscope. So, within that giant 90% epithelial group, this slide compares the two most common types, serous and mucinous tumors. And they have different personalities, so to speak. Serous tumors are more often found in both ovaries and are associated with BRCA gene mutations, while mucinous tumors are linked to KRAS mutations and even smoking. And this just illustrates the visual difference brilliantly. On the left, that's a serous tumor. It's often just a single, large chamber, uniloculated, and it's filled with clear, watery fluid. But then, look to the right. The mucinous tumor is multiloculated. It has many chambers, and it's filled with this thick, mucus-like material, which gives it that classic honeycomb appearance.
Okay, let's switch gears to a completely different category: germ cell tumors. These are really significant because they affect a much younger demographic, most commonly showing up in girls and women who are between the ages of 10 and 30.
And this right here is a classic example of a benign germ cell tumor called a dermoid cyst. Now, because these come from germ cells, which are basically the body's master cells, they can contain all sorts of developed tissues. In this specimen, you can clearly see hair and that thick, oily, sebaceous material. They can even have teeth or bone inside. It's pretty incredible.
Finally, it's so important to remember that not all tumors found in the ovaries actually started there. Some of them are metastatic. This is a classic example of what's called a Krukenberg tumor, which is a cancer that is spread to the ovaries, most commonly from the stomach or somewhere else in the GI tract.
And what's really fascinating about this one is its microscopic signature. When pathologists get this under a microscope, they see these very characteristic signet ring cells. The inside of the cell gets so full of mucin that it pushes the nucleus all the way over to one side, making it look exactly like a signet ring. It's a dead giveaway for this type of metastatic tumor.
Okay, so once the tumor is identified and classified,
we get to the final and most critical phase, creating that precise battle plan. This is all about figuring out the extent of the cancer and tailoring the treatment to fight it effectively.
The first part of that plan is staging. Using what's called the FIGO system, surgeons essentially map out the territory that the cancer occupies. Stage 1 means it's just confined to one or both ovaries. By the time you get to stage 4, it means there's distant metastasis to organs outside the abdomen, like the liver or lungs.
And that stage isn't just a guess. It's figured out through a really comprehensive surgical procedure. This is an incredibly thorough process where surgeons inspect the entire abdomen, they take fluid samples, they biopsy any suspicious areas, and they remove lymph nodes, all to map the cancer's exact spread.
In all of this diagnostic work, it all leads to the most important step, targeted treatment. The chemotherapy that comes after surgery is not a one-size-fits-all approach. For example, that common epithelial tumor gets treated with drugs like paclitaxel and carboplatin, while a rare germ cell tumor needs a completely different cocktail of medications to be effective.
So this entire journey, from just a vague feeling of being unwell, all the way to a highly specific chemotherapy plan, it really highlights the central dilemma of ovarian cancer. We have incredibly sophisticated ways to classify and treat it, but that's only after it's found. And that leaves us with the most critical question of all. How do we get better at hearing a disease that does everything it can to stay silent?